So whenever we are not talking, just remember to keep your microphone mute. And then when I call your name, you will be able to share screen and share your presentation. Once we finish your presentation and I announce the next one, then you stop sharing screen. Good morning, everyone. Good evening, good afternoon for those in different countries. We would like to welcome you to the monthly International Colorectal Web Meeting, and we have pediatric surgeons joining from Colombia, Mexico, United States, Spain, India, Philippines, Dominican Republic, Iraq, Romania, Bahrain, Libya, Austria, and Algeria. So welcome, everyone. The first presenter is Dr. Santiago Correa from Bogota, Colombia. I'm going to mute my microphone and you can share your screen.
Good morning. My name is Santiago Correa. I am from Bogota, Colombia. Thanks for the opportunity to share with you this case. Do you see the presentation? Okay. I'm going to start.
It looks good. No.
Thank you. We had a 13-year-old female with familial history of familial adenomatous polyposis with genetic confirmation. Mother died at the age of 35 of colorectal cancer. She was in prophylactic endoscopic and colonoscopy follow-up since she was 10 years old. And in 2021, we found a high-grade dysplasia in the ascending colon in one of the polyps. So we decided that she needed a prophylactic colectomy. And in August of 2021, we performed a total proctocolectomy with G-pouch ileorectal anastomosis. And we started the dissection of the rectum 2 centimeters above the petinel line. And then we remove all the specimen through the abdomen. On pathology, there were multiple tubular adenomas. The only one with high-grade dysplasia was at the level of the rectum. And at day 6, on the postoperatory follow-up, she started with systemic inflammatory response. And we performed a pelvic MRI with a collection. And at surgery, we found a complete dehiscence of the anastomosis. We tried to perform a neoanastomosis, but it was extremely difficult because of the length of the mesenteric vessels. We pursue for the second one, but on the postoperative, on the follow-up, few days for follow-up, we have to start enter again and perform an ileostomy. In the ileostomy, we leave more or less 40 centimeters of ileum, and that was closed at the level of the pelvis and was open at the level of the derivative ileostomy. This year, we were waiting that the patient adapt to the ileostomy, but she started with abdominal pain, vomit, and we performed a CT scan that we found that the distal ileum was getting dilated. So we suspected that the ileostomy was stenotic, or there was a problem with the ileostomy. So we entered to a third surgery this time, and reconnect the whole ileum and perform a terminal ileostomy. In this surgery, we identified that the length of the vessel was not as short as we expected, and the terminal ileum can reach below the level of the external genitalia. Also, in the anoscopy, we found that the pectinate line was still respected, and we have more or less 1 to 2 centimeters of rectum that is that are in good shape. So, in summary, we have a 13-year-old male with history of familial adenomatous polyposis with terminal ileostomy that might be definitive, and we are trying to pursue maybe through a posterior sagittal approach a new ileorectal anastomosis. The challenges with this patient is that the psychological outcomes of a definitive ileostomy. The patient desired for a closure, and the limitation of the mesenteric vessels. She's doing well with the ileostomy at the moment. She's going to school. We are managing the nutrition with good results, but she wants the closure. The major takeaways for this surgical experience, we decided that we're going to pursue to remove all or the most of the rectum that we can, and we did it through a Swenson approach. We decided this because she was very young at the first hydroid dysplasia. We believe that was important to stop pursuing it at that time, the ileorectal anastomosis, because we were losing ileum, and we are going to not have the opportunity to live, or she was not going to have enough length in a small bowel to adapt. And for an adolescent, it's difficult to adequate to or the the psychological adaptation to definitive ileostomy is going to be difficult. We have spoken with the uncle and with the patient that there are risks of fistula, vaginal fistulas, and that we were not able to perform this surgery as we expected. But we want to try, and that's the reason we want to present to you the case and to listen your opinion and your advices.
Thank you very much, Dr. Correa. So I'm going to comment on several aspects. So first, if this patient was in our hand, we normally don't do J-pouch. We would do a straight ilioanal anastomosis. So that's my first comment. I think she still is a candidate for an ilioanal anastomosis because the picture that you showed of the ilion going beyond the genitalia means that she has enough length for it to reach the anastomosis really well. Now, the other comment that I think it's important for all surgeons, you do a surgery. Once you have a complication, you have to recognize and accept, I have a complication. And I think instead of trying to rescue and minimize the complication, it's important that we do the right thing. So you have a dehiscence, this patient needs a stoma. It's very unlikely that you will be able to fix the anastomosis. There was clearly a technical problem that resulted in this dehiscence. So trying to put sutures in the tissue that it's not healthy, there is already an infection. So that was the only thing that if we could criticize, I think we would say, don't try to do that. Except I had a complication. Let's work on moving on. This patient needs a stoma now. It's very hard. As surgeons, nobody likes to have complication, and we agonize until we make the decision. But once we make the decision, I'm going to make a stoma, then the patient will do well, and you will be in peace. And then you have time to prepare for the reoperation. The other thing is, in order to operate on this patient that had a complication, I would personally wait at least 6 months. You want to make sure that all the inflammation is gone, everything is healed, then you're going to attempt. You want to invite someone that has experience in doing ilioanal anastomosis, because that's probably the last chance for this patient to have a good operation and preserve bowel control. And I'm glad you mentioned more than once that the anal canal is preserved. If this patient have continence, is only if we preserve the anal canal. If the anal canal is damaged, then there's no question this patient needs a permanent ileostomy. And regarding the removal of the rectum, in those cases, we have to remove everything because of the risk of cancer. You just preserve 1 centimeter to be sure that the anal canal is preserved, and that has to be scoped and screened for cancer as well. There's a question, can you please repeat why you would perform the ilioanal anastomosis? The reason is the J pouch is created with the idea to decrease bowel movements. So I don't see the difference between a J pouch and the ilioanal anastomosis. I think patients adapt and behave well. And the ilioanal, in my opinion, it's an easier operation, less chance of complications, and the results, I think, are the same, honestly. Anybody else wants to comment? Any other questions? Dr. De La Torre?
Yes, I have a question for Santiago. Santiago, thank you for presenting this case. I just want to know, in your opinion, in retrospect, what was the cause that you have the first dehiscence?
I believe that when we put the bowel outside of the abdomen, the perfusion of the bowel was perfect. But as soon as we put the bowel through the pelvis, start to get ischemic. So maybe we performed the anastomosis was not as well perfused as you have to do it.
You mean the pouch, right?
Yes.
Okay. Okay. Thank you, Santiago.
Thank you, Professor.
Thank you so much for presenting this case, and keep us updated on how she's doing and when you're going to operate on her.
Thank you. And the second question, I want to do it through, I want to ask for help. Normally, we perform all the surgeries with my colleague. But you will try it through a sagittal approach or not?
Thank you for asking. I forgot to comment on that. So we try to use the posterior sagittal approach in those cases only if you find a frozen pelvis that cannot be approached transanal and through the abdomen. The reason why we try to avoid the posterior sagittal approach is because you're dealing with a patient that has normal anus, normal bowel control. So if you do a posterior sagittal approach in a circular anastomosis, you end up with a T in the posterior sagittal. So the chances of fistula to the incision is extremely high. In the event that you enter, you find a frozen pelvis and you need to go posterior sagittally, then you need a protective stoma, because otherwise these patients will have a fistula. It's very common in patients with normal anus that you do a circular anastomosis to develop a fistula from the circular anastomosis to the posterior sagittal incision. So I would say you leave the posterior sagittal as an option, but it should not be your primary approach.
Thank you very much, Professor.
So our second case will be presented by Dr. Itzel Lizagarra from Mexico.
Thank you, doctor. Thank you. Good morning. This case is of a female of 18 years old with anorectal malformation with rectovestibular fistula type, an absent vagina, and she is fecally continent with a sacral radio of 0.6. At the 8 months of life, a PSARP and a distal vaginoplasty was performed, and they found a lower vaginal atresia. Of the 12 years, she suffered of severe abdominal pain, and she entered to exploratory laparotomy with drainage of hematocolpus of 350 milliliters, and they placed a vaginostomy. After 13 years, the vaginostomy was dysfunctional, and she has to enter again to a drainage of hematocolpus of 50 milliliters, and then she continued with fever and pain, and she entered again for an exploratory laparotomy, resection of the left remnant vagina, and drainage of a pelvic abscess. At the 16 years, she was doing okay, but she stopped doing vaginal dilations, and the menstrual period was through the vaginostomy. At the 18 years, she arrived to the colorectal clinic, and we decided to do an examination under anesthesia, and we found this. We can see the distal vaginal atresia with a normal urethra. And we asked for an MRI. In the MRI, we found that we can see the proximal vagina dilated and filled with mucus. The bladder and the rectum were normal. So what would your approach be? Transanorectal, anterior sagittal approach, proximal vagina pull through, total vaginal replacement with bowel, or posterior sagittal approach with mobilization of the rectum and proximal vaginal pull through. Okay, so the thing we do was the transanorectal anterior sagittal approach and the proximal vagina pull through. A Foley catheter was placed, then the patient turned into the prone position with the pelvis elevated, and the genitalia and perineal area was properly prepped. Here we can see the distal vaginal atresia. And we place 5 silk stitches for reference and then start with the anterior incision. We continue with the incision and decide to open the anterior rectal wall through the midline until we find the vagina. We find the vagina approx 7 centimeters into the deep, and that's why we have to open the anterior wall of the rectum. Here we can see the better image of the proximal vagina. Then we placed 5 silk stitches and open in the middle and drain about 100 milliliters of vaginal content of mucus. And we placed all around the incision of the vagina stitches, then to pull through the vagina until we reach the perineum. We continue to proceed and made the introitus, and then made the vaginoplasty with 5 stitches of Vicryl around the vagina and the perineum. Then we close the anterior rectal wall, and this is the final result of our patient. Actually, the patient is with normal periods through the vagina. It's pending to do another examination under anesthesia in the next 3 months, and she is fecally continent.
Thank you very much.
Thank you.
This is a very beautiful case. So I just want to comment on a few points. One, we use the transanorectal approach when the patient has bowel control. If the patient has bowel control, we don't want to mobilize the rectum again, risking decreasing the chances of bowel control. Now, when we open the rectum, we have to put stitches as we open them so we can close them correctly. And if we are doing this case, we do a full bowel prep and we keep the patients 7 days NPO on TPN. So I think the key image here is the MRI. I don't know if you can put back, Dr. Lizagarra, the MRI, because that will guide you if you have chances to approach this vagina posterior sagittally through the perineum or not. So in this case, you want to see the sacrum, and you know that if you enter, you will be able to find this vagina. So, but you have to be prepared in case it doesn't happen to other options. When the patient has a vaginostomy, it's very good because you can inject saline through the vaginoscopy, and that helps you find this structure when you're entering through the perineum. And the other question is, how old is the patient now?
It's 10 years and 4 months, more or less.
10 years? Okay.
She's 18 years? 18.
Oh, 18 years. Okay. If she's 18 years, I would definitely dilate this introitus, because 18 years she can understand and she can engage with you and do dilations, and that will avoid the need of, sorry, my paper fell, of a future introidoplasty. So if she dilates, just like you do the anal dilations, but you're just gonna dilate to a bigger size, thinking of future intercourse, and that will avoid the need of a future introidoplasty. That would be my only recommendation. Any questions or comments? So I would say this case end up being an acquired distal vaginal atresia, because the patient had a procedure during the PSARP and then had an acquired distal vaginal atresia. Ideally, we want to repair the vagina and the anus at the same time. That's when you have the best exposure, and I suspect this case would have been easy if it was in the right hands. But I'm glad the patient found you, and it's doing great. Congratulations on the surgery.
Thank you, doctor.
Our next case will be presented by Dr. Christine White from New York. Welcome.
Can you all see?
Yes, we can. Looks good. And we can.
Congratulations to the previous presenter. That was fantastic. So this is just a little clinical problem that we encountered in a patient who had previously had surgery for Hirschsprung disease. And we did imaging and biopsies, and I wanted to share the information with the group because I personally found this information difficult to assess. I found it difficult to assess the imaging and pathology results before coming up with an answer. So, okay. So this little boy came to see me when he was 3 years of age. He had surgery with another surgeon. He was now 3, and he had a history of sigmoid Hirschsprung disease. He'd had a pull through in infancy, And the problem was intermittent abdominal distension and failure to have regular bowel movements. And these are the SCOUT films, and they're kind of non-specific. All you see is some distension maybe there in the left upper quadrant in the proximal left colon. To go into his history a bit more, he was born in 2019 at term, and he weighed 3.4 kilograms. During the pregnancy, he had been noted to have a cystic hygroma. He failed to pass meconium. He had Hirschsprung disease confirmed on a suction rectal biopsy on day of life 4. He had a diagnosis made of Mowat-Wilson syndrome, and he had hypotonia, he had penile hypospadias, hydronephrosis. His surgeon at the time sent him home on rectal irrigations and brought him back for pull-through. Mowat-Wilson syndrome is a genetic syndrome with developmental delays, facial features, sometimes cardiac anomalies. And the most important thing for us is that 50% of individuals with Mowat-Wilson syndrome have Hirschsprung disease. So when he was 9 weeks old, his surgeon did a laparoscopic pull-through and found a transition zone in the sigmoid colon. They did a primary anastomosis. The pathology at the time showed good ganglion cells with no nerve hypertrophy at the level of the anastomosis. It was noted at the time that the surgeon had placed the anastomosis somewhere about 4 centimeters above the upper limit of the aganglionosis. Unfortunately, he leaked and underwent an ileostomy on day 6 for an anastomotic leak. However, 3 months later, he had closure of ileostomy, but then he leaked again from his ileal anastomosis, and the surgeon revised the ileal anastomosis on day 5, and thankfully, everything healed at this point. So that was when he was an infant, and we're talking about him now. He's 3 years old. In the meantime, he had some hypospadia surgery and so on, and he overall did reasonably well. But then he came in to see me, and this is from my clinic note in July of this year. I wrote down that he was doing fine, but for the past month or 2, he seems to just pass small amounts of gas and stool all the time. His colon is distended, and the mother can see it sticking out. She's doing irrigations every other night. He was not like this before. So I booked the little boy for a contrast enema and Botox injection, a biopsy, and I wanted to do a trial of oral metronidazole, but our local liquid metronidazole tastes terrible and the patient wouldn't take it. So anyhow, we did, when I examined him in the OR, he had a softly distended abdomen and the anus looked good. And when I did a rectal exam, the anal tone was okay. And there was a lot of liquid stool in the rectum, which flowed out in the operating room. I did a sigmoidoscopy to 20 centimeters. The scope passed just fine. I didn't notice any obstruction. I did not see a colitis. And I gave him 50 units of botulinum toxin. So the biopsy showed abundant ganglion cells, and the calretinin was positive. The pathologist commented that there were some occasional nerve trunks with hypertrophy to 50 microns. She also reviewed the original pathology and said it was fine at that. The original pathology was fine with no nerve hypertrophy. And she also reiterated that the original surgeon had placed the anastomosis 4 centimeters above the upper limit of the aganglionosis. This is the pathology from my biopsy. So it's a postoperative appearance. So here you see the hypertrophied nerves up to 50 microns through part of the biopsy. The pathologist noted nice ganglion cells. She did a calretinin stain, which is positive, and she felt that it showed normal intact mucosal innervation. And this again is a view of the ganglion cells close up. They're nice, normal looking ganglion cells. And here the nerves are actually normal in this part of the biopsy. We did a contrast enema. As you can see on the scout view, there's some dilation in the proximal descending colon. And here in the view on the right, you can see the sacrum, and you can see the normal looking gap between the sacrum and the pull-through bowel. And just there's this kind of caliber change here in some of the views where the rectum looks a little bit narrow compared to the proximal bowel. And we were kind of worried about that, and we looked at it a lot. Here you can see it again, like the rectum looks kind of narrowish, but proximally it looks wider. But then in this view taken a few minutes later, the rectum seems to have opened out. This is the post-evac view with some retention of contrast, with a normal looking kind of rectum on the left, but then on the right, it looks a bit narrow. So all kind of non-specific findings. So just to reiterate, we have a 3-year-old with Mowat-Wilson syndrome with obstructive symptoms post-pull-through. His biopsy showed good ganglion cells, but a few hypertrophied nerves. And the contrast enema showed a possible narrowing at the upper rectum, but the scope went through and the narrowing seemed to be transient. So I kind of wondered what to do with this little guy. So in August, I gave him Botox 50 units and we did irrigations at home. And he was not doing well, and it was driving the family crazy because there was, he resisted the irrigations and lots of crying every night, and family were having a really hard time, and his symptoms didn't change very much. I saw him a couple of months later, he was still having a hard time. So around this time, I looked on the Hendren website and I found a lecture by Dr. Della Torre on this subject of obstruction after Hirschsprung pull-through, and I found it very helpful. So I did more Botox. I gave him another 50 units of Botox into his sphincter, and this time I started him on Senna, 2 chocolate squares at night. Each of those squares is 15 milligrams, so it's a big dose of Senna. And I also got him to take his metronidazole this time. So he took 5 days worth of metronidazole. And the parents continued with the irrigations, but they were able to diminish the frequency of the irrigations. And he got better slowly. He really got better with just a repeat Botox and more Senna. And so far we are doing okay. We are keeping an eye on his nutrition, and the family are a lot happier. I haven't seen them now for about a month or so, so I'll be seeing them again soon. And I guess my questions, and the reason I'm presenting this is, what do you think of that contrast enema that I showed you? I mean, is there any significance to that transient narrowing there in the rectum? Should I be worried about it? And what about the biopsy result? I mean, it shows abundant ganglion cells, but there are some hypertrophied nerves that are pretty obvious there. Do you think that we will ultimately be successful with this little boy? That we will do fine continuing on our medical management? And when, with these kind of patients, do you give up and do an ileostomy? And has anybody had experience with this Mowat-Wilson syndrome, and how did they do in the long term? Thank you very much for your attention.
Thank you very much, Dr. White. I will let Dr. De La Torre comment, but I do think you will win. That's just my prediction. And I have to say, I am personally very conservative before offering a reoperation, especially when you have a surgery that was done well and a biopsy that shows good ganglion cells. But I think it's our obligation to prepare parents before surgery, because I think many surgeons have make the mistake of saying, oh, we're going to operate and your child will be fine. I always tell my Hirschsprung patients, we're going to do the operation, but you are my patient for life. We will be managing you for life. We cannot fully explain why some patients have enterocolitis or not. You will be always ready to do rectal irrigation. So I really prepare them for a chronic condition. Dr. De La Torre, your comments.
Thank you. Thank you, Christy, for this case. Can you put the last slide of your presentation?
Sure. Okay.
Perfect. Thank you. Yeah. So what do I think about the contrast enema in this particular case? I think this patient was not managing properly before you with irrigations. This patient shows the typical image of chronic dilation of the colon, and this patient needs irrigations. He needs aggressive decompression with enemas, with irrigations, with Senna, whatever. We need to move this colon. Patient with more Wilson syndrome, they have hypotonia, so they are not good candidates like other kids. It's very similar that happened with Down syndrome patients. I don't know if this patient is taking medication for seizures. Many patients with Moat Wilson's take medication for seizures. The biopsy, this is amazing. And I want to say something, and I want to be very clear. When you do a pull-through and the patient is not doing well, and then you think that the surgeon did a pull-through in aganglionic segment, in other words, he created a neorectum with aganglionic bowel, that's the indication to take a biopsy. If the proximal margin that was used to create the neorectum has ganglion cells and no hypertrophic nerves, in other words, is normal, is not in transition zone, then months or years after the pull-through, if you take a biopsy of the neorectum, you are going to find this beautiful image showing ganglion cells and hypertrophic nerves. So you don't need to do anything with that. That's normal. The hypertrophic nerves in patients after the pull-through is a normal phenomenon. The extrinsic nerves after the pull-through grows into the bowel like a new innervation, and you do a GLUT1 immunochemistry, you will find these hypertrophic nerves. These hypertrophic nerves came from outside, so it's not a transition zone, and you don't need to do a reoperation just because these histological findings. Yes, I agree with Andrea, you will win. I am more aggressive with the Botox. I use more than 50 units. If the patient is less than 10 kilos, I use 100 units. If the patient is more than 10 kilos, I use 200 units. I am more aggressive in that. And right after we denervate, we do the chemodenervation with Botox, we start very aggressive with enemas, which is better than for the parents, I mean, than irrigations. And if he's doing well with enemas, then we can transition to the use of Senna. I do an ileostomy or end colostomy in patients that is the last resort that we use. And what about this syndrome? As I already said, yes, 50% or little more, the patient with this syndrome, they will have, or they born with Hirschsprung. So yes, we have experience with this syndrome and Hirschsprung, and usually these patients are doing okay, but they need more aggressive bowel management for Hirschsprung after the pull-through. So I think you are doing the best for this kid. Keeping doing the same. Try to use more Botox in this patient, and I do not recommend to do a reoperation with these histological findings. I don't know, Christy. Thank you very much. This is an amazing case.
Thank you. Thank you. And just to say again that, you know, your video, I encourage the audience, have a look at Dr. De La Torre's video on the website on this subject. It was really, really helpful. So thank you very much for that. Thank you.
Thank you.
So Dr. De La Torre, I don't know, is in your YouTube channel, do you have a video showing the Botox, how you inject Botox?
Yeah, it's in Spanish and in English.
Okay, so that's another good video to look. I don't know if you can share on the chat your YouTube channel and then people can go and look. So our next case will be presented by Dr. Carolina Giraldo from Mexico.
Good morning. My name is Carolina Giraldo. I am a pediatric colorectal fellow from National Institute of Pediatrics here in Mexico. This case is about a 1-year-old male patient with a history of bilateral hydronephrosis diagnosed prenatally. After birth, grade 5 vesicoureteral reflux was diagnosed. This patient had an anorectal malformation with rectoperineal fistula, bucket handle type. At birth, at another hospital, they performed suprapubic cystostomy with ablation of posterior urethral valves and anoplasty. Apparently, they only excised the bucket handle. This is the patient, and we can see here the rectoperineal fistula. In the left picture, we can see cystourethrogram with grade 5 bilateral vesicoureteral reflux and bilateral hydronephrosis seen in the ultrasonography. This patient presents multiple febrile urinary tract infection as acute pyelonephritis with isolation of E. coli with extended spectrum beta-lactamase, delaying his surgical treatment. After antibiotic management, cystoscopy was performed by the urology service, finding a complete stenotic obstruction of the urethra. A vesicostomy, bilateral bladder urethral reimplantation, right urethral plasty, and circumcision were performed. This was his contrast enema, presenting megarectum and megasigmoid with a pelvic rectum index of 0.9 being abnormal. So we decided to perform a colostomy. Posterior to the vesicostomy, it was possible to perform a double study in the same time, cystography and ureterography, observing urethral stenosis at the vulvar and prostatic urethra. So this patient had a rectoperineal fistula and a vulvar urethral stenosis. We decided to perform sagittal posterior approach with urethroplasty at the same time of the anorectoplasty. We started with a sagittal posterior incision, then divided the entire sphincter mechanism. Then multiple stitches were placed in the fistula for uniform traction, facilitating the dissection of the rectum. Here we complete the dissection of the rectum, separating from the urethra. In the right picture, we can see the peritoneal reflection. After mobilization of the rectum, the urethra could be dissected to perform the resection of the stricture and anastomosis. This is the distal urethra after dissection. Then proximal urethra was dilated. That was dilated is identified and dissected. This is the end-to-end urethral anastomosis with absorbable suture and 8 French poly catheter inside. Then we reconstructed his perineal body and performed the anorectoplasty. This is his final appearance. Thank you.
Thank you very much. This is a beautiful case. Anybody has any questions? So I think this illustrates that not all rectoperineal fistulas are made the same, and not all of them are straightforward cases. And the importance of looking at all associated anomalies. So in the male patient, if there is a problem with the urethra, that's the perfect time to address it, because you will have an excellent exposure once you mobilize the rectum. The same is for female patients. So if you have a vaginal problem, that's the time to address, because you will have the best exposure. So this is a beautiful case. Congratulations, Dr. Carla Santos and Dr. Carolina Giraldo. If there are no questions from the audience, then we're going to move to the last case, that it's also a rectoperineal fistula that I'm going to present. So this is a 15-month-old female patient that had a late diagnosis of a rectoperineal fistula due to severe constipation. So she was seen multiple times by the pediatrician, parents complaining, diaper rash, severe constipation, and the pediatrician saw that the anus was smaller than normal, and he labeled as anal stenosis and told the family, since she's stooling, you don't have to worry. And the family insisted and was not happy because the child was really suffering with the constipation. So they went to the pediatric GI, and it was the pediatric GI that referred the patient to us. So here is the simple abdominal X-ray film when I initially saw the patient. So what caught my eyes was this obvious constipation. You can see a lot of stool. And from this X-ray, I had the impression that the sacrum was not normal. This is a little, you can see that the patient is a little rotated, but I was wondering if this was a hemisacrum. So we ordered sacral X-rays, and here comes our first surprise, because this is a rectoperineal fistula, but take a look at this poor sacrum. So the sacral ratio was 0.35. So what studies would you like to order? Contrast enema, kidney ultrasound, spinal and pelvis MRI, options 2 and 3, or all of the above. So everybody can vote, and let's see the results. Do we have a poll? I don't see a poll. Ray? Okay. So you can type in the chat, what are your options? 1, 2, 3, 4, or 5? So far the majority is saying 5. Some people saying 4, but the majority is saying 5. Very good. So if you have a late diagnosis of rectoperineal fistula with severe constipation, I normally get a contrast enema, because you want to know how dilated this rectum will be, so you are prepared in case you need to do tapering, or if you think this patient would be better with a colostomy. So that's why I think in a late diagnosis is wise to ask for a contrast enema. We'll always ask for kidney ultrasound. In this case, with the first X-ray that I had the impression that it was a hemisacrum, I want a spinal MRI to rule out a presacral mass, and I want a pelvis MRI to rule out a presacral mass, and a pelvis and a spinal to rule out tetrachord. So I would say all of the above. That's what we did. So this is the contrast enema. So it was not dilated rectum, which was good. And you can see in the kidney ultrasound, we had bilateral hydronephrosis. We had a blunt conus on MRI, no tetrachord. and we had no presacral mass in the pelvic MRI. Now, surprisingly, because I had examined the patient and I had seen the vagina, the MRI reported no visualization of the vagina and uterus. So with that information, what do you propose? PSARP and vaginal reconstruction at the same time, PSARP only and vaginal reconstruction at a later time, or I don't know. Everybody can vote, and I'm curious about your answer, assuming that the report is correct. So the majority said PSARP and vaginal reconstruction at the same time. So that's what I would do. Luckily, we didn't need to entertain this discussion, because when I looked at the MRI, I could see the uterus right here. That's the cervix, that's the uterus, and this is the vagina. And then even in the spinal MRI, we could also see the uterus right here. But during the operation, we always start with a vaginoscopy. And what was surprised, she didn't have one vagina. She had two vaginas and two hemicervices. So she had more than one. This was what I call more into the benign side of the rectoperineal fistulas from looking at the perineum, meaning she had a little bit of perineal body and the parents were dilating the fistula. That was instructed by the pediatrician. I never dilated pre-op, but we opened posterior sagittally. We separated from the vagina. And here you can see the vaginal septum that we resect during this operation, making a single vaginal cavity. But it's very important to inform the parents that she has two hemiuteri. And we have to monitor this patient, since we didn't go into her abdomen, at the time of menstruation to assure that both of them are patent and draining. So here you can see, and in this picture, you can see that the fistula was located here at the beginning of the incision, but the center of the sphincter is here, marked with the silk stitches. So here is the reconstruction. And in this patient, I bring this case again to demonstrate that not all perineal fistulas are made the same. Usually when we diagnose a perineal fistula, we tell parents good news. This is the most benign type of anorectal malformation. Your child will have bowel control. This is not the case. This is a case in which she has a rectoperineal fistula. She will not have bowel control. And it's very important to explain that to the family. The other portion that it's extremely important to explain to the family is that the constipation will persist despite the operation. If they know that preoperatively, they will understand when it happens postoperatively. If you don't inform them, they will think you did something wrong. So not all perineal fistulas have good functional prognosis. And a very hot topic, but vaginal reconstruction in anorectal malformation is different than in other conditions. When a patient has DST or Mayer-Rokitansky is a completely separate discussion. In patients with anorectal malformation, once we separate the rectum, that's the best time to reconstruct the vagina. So any questions, concerns, comments about this case? Is there anything in the chat? I don't think so. Let me just move my slide. So I would like to thank you everyone for this amazing year together with the Hendren Project and the International Colorectal Web Meeting. I know Ray's gonna publish the next year dates for our monthly International Colorectal Web Meeting. And we hope you can all join us, continue to share cases. I think we all learn from each other when we share those very interesting cases. And I'm very grateful for all of you. And I hope you have a wonderful holiday season. You can hug many people, help many people, be compassionate with your patients, and continue to be here. So today we had pediatric surgeons from Colombia, Mexico, United States, Spain, India, Philippines, Dominican Republic, Iraq, Romania, Bahrain, Libya, Morocco, Austria, Algeria, Peru, Montenegro, Uganda, and Guyana. I hope and Czech Republic. I hope I didn't miss anyone, and it has been a pleasure. Dr. Peña is today in Mexico, that's why he didn't join us, but he will be here in the next one. So thank you, everybody, and happy holidays.
I want to jump in here real quick and say many thanks from the Hendren Project for the work that Andrea Bischoff does, and also with Luis de la Torre and Dr. Alberto Peña, of course. They do a fantastic job pulling this thing together every month and bringing this discussion live. So many thanks to them, and many thanks for all the attendees. We have many repeat attendees, and we appreciate that. And we hope you will come back to the Hendren Project to find these videos online pretty soon. So thank you and have a great holiday.
Bye, everyone.
Thank you, Ray.
Thank you.
Thank you, everyone.
Thank you.
Thank you for calling.